You know a lot about the hospital industry, so that's what's medical centers, the traditional Harvards and the Johns Hopkins, even those tertiary respected places, much more so the lesser ones, are getting killed by this bad economy because fewer people have insurance. They're coming in with a higher mix of Medicaid. They don't have the Cadillac insurance that lets them get the hips and the stents, so maybe
that's right. I mean, when you look at one of the byproducts of this recession is that people have been putting off major medical procedures longer, and you see it in the utilization of medical devices and the inpatient admissions in hospitals, which have been falling in all categories, particularly the lucrative commercial business that these guys have, except Medicaid, which has been growing as a very fast percentage of the case mix. And as we all know, hospitals lose money on Medicaid business, and that's a real challenge that they have to figure out. Now, Tom, you pointed out earlier before we started filming that that's the case, and yet every hospital is building a new wing and has a crane in front of it and implementing $1 billion electronic medical record system. So
and we own 2 hospital chains in my firm, so
yeah.
It's just, I mean, some hospitals are struggling, but
most
are doing very well.
Some are, but I think the bigger question is, as this expansion that we talked about happens, what's going to happen to the state of hospital balance sheets, and are they going to be able to sustain an influx of additional Medicaid patients at rates that are significantly lower than the commercial business that they usually take in? And that's a real open question in my mind for the viability of physicians and hospitals.
I'm going to bounce it back to you guys because you guys know I have no experience in industry, and I work as a practicing doctor in a nonprofit health center and academic research. So when we clearly all agree that Medicaid pays below commercial, there's no doubt about that. And so to the extent that we were shifting a lot of people from private into Medicaid, we'd be seeing a real impact there. To the extent, if the expansion were perfectly targeted, which it won't be, but let's say it was perfectly targeted, and the only coverage shifts were people who were uninsured, who were either paying out of pocket or bad debt or uncompensated care into Medicaid. Strikes me that at least for the majority of providers, that would actually have to be a net gain. Now,
huge for hospitals.
Right.
No, that's why the AHA and the Federation of American Hospitals, which I used to run, cut that deal. They want universal coverage, and they'd rather have Medicaid payment at 60 cents on the dollar than nothing.
Right.
So we own a system in Tulsa, which has, believe it or not, I think 25% uninsured. So if you have all those patients coming into your hospitals with nothing, you're going to be a lot happier having Medicaid.
The question is, will they follow the pattern of utilization that everyone else follows when they get insurance, which is when you have insurance of any kind, even if it's Medicaid, okay, you won't be using the ER and therefore that bad debt expense will be gone for the hospital, but you will start using other medical services because you'll get preventative care, and therefore those medical services that compensate the hospital at a far lower rate. And to me, there's an open question there.
Well, they probably will still use the emergency room. That's what the studies suggest, that when people get insurance, they still use the ED, but the hospital gets paid for that visit instead of just racking it up as bad debt. And so I think if a for-profit hospital was making its decision, of course, everyone in the U.S. would have private insurance and pay private rates. But that's not the reality of any of the options on the table. What we're talking about is
good time to talk about your paper related to this. You said if you expand Medicaid, you looked at states that did it impact health, mortality?
So, interesting, we've kind of started focusing on the cost, which I think is the majority of where the attention goes, both in industry and in government when we talk about Medicaid. But I work at a school of public health, and I'm a clinician too, and thinking about the public health implications of expanding coverage, we did a study where we essentially wanted to look at expansions that were as similar as possible to what's going to happen under the Affordable Care Act with Medicaid. So we looked at 3 states, New York, Maine, and Arizona, in the early part of the decade, through waivers with CMS, significantly expanded coverage to the childless adult population, basically up to about 100% of poverty in those 3 states. And this is essentially the same group. We're talking about slightly different income cutoff as the ACA. And we followed them 5 years out, compared those states to neighboring states that were similar in demographics but didn't expand Medicaid. We looked at coverage, coverage impacts, how much of it was shifted from private versus an actual drop in the uninsured. We looked at people reporting barriers to care in terms of costs, so access to services, their self-reported health, and then ultimately their survival, the mortality rates. And what we found was that Medicaid was fairly effective for all of its flaws, which I think we all agree it's got numerous issues at the state and federal level. People mostly were shifting from being uninsured, so declines in uninsured rates. We saw a significant decline, about 20–25% decline in the number of adults who said they couldn't afford the care they needed, so they were able to get services. Improvements in self-reported health, and then the actual mortality rate in the 20 to 64-year-old age range dropped by 6% compared to baseline in these states.
And I don't disagree with that, but the other issue you got to look at New York's, God bless them for doing that. California spends a third, has just as many insured people. California is much more earlier to go to managed care, much more efficient. They spend a third as much on each person. Their coverage is much more efficient and much more rational. So some of those issues, look, everybody'd like to have coverage. The issues, how do you do it with the right set of incentives and do it rationally? In my opinion, California is a hell of a lot better model than New York. New York is like $8,900 per capita.
Yeah, well, I think there's always, economists like to distinguish between what's going on the margin and what's going on overall. And the level of spending in the healthcare system as a whole, I think in the U.S. we probably all agree overshoots what we get in terms of the benefit from it. But on the margin, providing coverage to uninsured people seems to be one of the more effective things we can do for public health. But completely agreed that we ought to. That's not to say we don't need to fix it exactly.
This is a good tie-in of two different. Your paper, you said you looked at expansion of Medicaid and it led to changes in health. You were asking if people expand under the ACA law, what kind of utilization? Will they start getting more hips, knees, and stents? And my question to you after we interviewed you on your paper was, what services do you think people were getting with the expanded Medicaid that led to better health? Were they the primary care, emergency treatment? Any thoughts on that?
Everything. I mean,
if you give people Medicaid,
he's the
what's
statistician. The general rule of thumb is that an uninsured person consumes about 60% of what an insured person. So they're still going to the emergency room, they're still getting services, but there's a barrier to entry, and hospitals and physicians try to avoid giving them more service than they need, and they've actually about 60%. So the same person who's uninsured on day one is going to get 40 or 50% more on day two. And once again, if they go from Medicaid to commercial, they'll get that much more because a lot of physicians and hospitals frown on Medicaid.
Let's